What is important is I think the laboratory has a huge role to play in this pandemic and quite central in the theme. In recent times, the coronavirus outbreaks have been, in the year 2002, it's been SARS, followed by MERS, and then now it's COVID-19. And you see between SARS and MERS, it was 10 years, and between MERS and COVID, it's 7 years. So I don't know whether to read too much into that. Currently, the mortality data of MERS-CoV is the highest at 34%, SARS is at 10%, and currently COVID-19 is at 2 to 4%. Looking at, and that keeps coming on a daily basis in our newspapers. Incidentally, what happened was on 31st of March, we received a circular from Government of Karnataka that we, being a lab approved for testing COVID-19 samples, had also to be doing fever clinics. So fever clinic is essentially a role of a hospital, but in these times, they expect the testing labs to double up as fever clinics as well. And they have a nice algorithm to indicate when a patient with symptoms, they would do a triage using the ICMR criteria. And then if it is a suspected COVID-19 with high risk and moderate to severe symptoms, they would go straight to the COVID hospital. And if it's mild or moderate, then they would get into a swab collection center. The swab would be collected and then sent across to the testing center. While the reports are awaited, the patients are taken to hotels designated as quarantine centers. And once the lab results come, if it is negative, they would be advised home quarantine. And if it is positive, in mild cases, a supervised isolation center, and in a severe case, a designated COVID hospital. Now, this is the workflow that the government of Karnataka laid out for us. And that's where we decided that we had to document our processes, and the activities involved in COVID-19 testing would include a fever clinic, a flu corner. We are currently not taking on this role. We are, in fact, developing infrastructure and processes to double up as a fever clinic. We have not started sample collection in our lab. However, we are trying to look at using the drive-through collection and then go ahead and have a dedicated collection booth. And finally, of course, we have been testing for the last 2 weeks. Now, when you look at each of these activities, the fever clinic basically receives patients with complaints of typical flu. And then the fever clinic has to take details of demographics, travel history, COVID contact, and congregation, if at all there is one. And then go on to do a clinical examination, which includes temperature, weight, BP, chest examination, and oxygen saturation with a pulse oximeter. And then triage to see if the person needs a collection to be done or not. All along, we have to ensure safety of staff and patients. Now, if a patient deserves to be tested, then a sample collection has to be done. And this requires that there is safety of patients. Staff have to be ensured that they are safe. A sample collection should be done. And typically, its current recommendation is that it's nasopharyngeal swab. We can take an oropharyngeal swab in symptomatic cases. We ensure that there is disinfection of area surrounding the patient and ensure proper disinfection of the outer surface of the sample container, because that's a surface contact with the patient and probably the virus. Of course, when it comes to testing, we have to ensure safe transportation of samples to the testing area, accessioning, opening and managing of the viral transport medium, biosafety cabinet, RNA extraction, master mix preparation, amplification, quality control, reporting as per the criteria, ensure proper communication to patient, hospital, and the government, and finally, and not the least, biomedical waste management. Now, the government of Karnataka shared their standard operating procedures for flu corner or a fever clinic with us, and reasonably good to see how they have laid out the administrative planning the timings of the clinic, what staff should be there, who are the personnel who should be involved, what is the engineering requirements. And interesting to see that the waiting area should be well ventilated, natural ventilation, exhaust fans should be used, avoid ceiling fans and air conditioning. Of course, social distancing and hand sanitization and mask is essential. The healthcare workers need to have personal protective equipment to ensure that they are covered and there's no exposed area which can get contaminated. Disinfection of the flu corner is very essential, hand hygiene, and of course, patient movement protocols. So with that SOP, Dr. Ajit, my colleague in radiology and clinical imaging, came up with this workflow where he had one coordinator taking care of all the patients who walk into our lab to do the triage. They would, as they enter, they would we would insist that the patients have hand hygiene either through soap and water or hand sanitization, check their temperature, and provide a mask if they're not having one. And following this, the person would decide whether that person gets into the fever clinic or gets into a routine test area. Now, those who come for the fever clinic would be in a waiting lounge where demographic details, contact numbers, address, photograph, and ID proof would be taken. And then a nursing station where temperature, weight, BP, and oxygen saturation would be collected. This would lead to the physician who would check and depending on the ICMR criteria for COVID-19, decide whether the sample needs to be collected or he or she needs to go for other tests and not necessarily COVID testing. Now, when they refer to COVID testing, the collection happens and they are sent to an isolation area. Only if the test is negative, they are sent back home and asked to quarantine themselves. If the test is positive, they are taken to an isolation hotel or a hospital. So much for the fever clinic or the flu corner. From there, I move on to the sample collection, which I believe is very critical, particularly if you have to get good results from the molecular testing. Currently, we are looking at two possibilities: the drive-through sample collection facility or a dedicated sample collection area, which includes a biosafety booth with negative pressure, virus burnout, and a BSL-3 practice. This is the current drive-through which we use for other tests. We are not doing it currently, but we intend to convert this facility into a drive-through swab collection. And this will happen over the next 5 days to 7 days. The other design which we are coming through is a biosafety booth, which is nearly hermetically sealed. It will have a negative pressure. It will have a BSL-3 practice. Disinfection is easy because it's a booth which is 4 by 6 by 7 feet in height, and it ensures safety of patient and the staff. There are many booths that have been going around in the newspapers, and I'm sure many of you have seen this. But my concern is that this can lead to more risk than anything else. If you see, this is a booth which is indoor, and inside is the healthcare worker who is taking a swab. Ideally, if this person is asymptomatic, the only swab he should be collecting is a nasopharyngeal swab and not an oropharyngeal swab. But in this case, it's an oropharyngeal swab. The other concern is that the person who is outside is liable to contaminate people who are standing around him. So the recommendation is, if there are outdoor booths, the healthcare professional is inside the booth with an air conditioning and a positive pressure. The patient is outside the booth with ventilation, well ventilated. And of course, social distancing has to be maintained even though it's outside the booth and outdoor. The booth has a positive pressure. Because the healthcare worker is inside the booth, and the air movement should be from inside the booth to the outside, so that when the patient is standing outside, his aerosols do not enter the booth. And finally, the disinfection is that of the booth from the outside. If there are indoor booths, then the healthcare professional is outside the booth, the patient is inside the booth. There's negative pressure inside the booth to ensure that all the air that is inside the booth is sucked out and it goes through a virus burnout and ensures it is safe. And disinfecting the booth is from the inside after every patient. Now, the diagnostic respiratory specimen, it's very important because that is the primary specimen for COVID-19 testing. While we are considering this, it's important to look at the healthcare professional in the room should wear N95 mask. There should be eye protection, gloves, and a gown. The number of healthcare professionals should be at the minimum. Visitors should not be present for sample collection. Specimen collection should be performed in a normal examination room with the door closed. Now, this is where we are considering the biosafety booth, because if there's a normal examination room, the possibility of contamination is very high. And the next point, which is cleaning and disinfecting the room, can become extremely challenging. So when you look at the CDC website for specimen type and priority, it's very important to look at the nasopharyngeal swab for testing asymptomatic persons in a healthcare setting, including long-term care facilities. Because at this time, anterior nares and mid-terminate specimen collection are only appropriate for symptomatic patients, and both nares should be swabbed. Now, it's also important to look at the recommendation for collecting and testing an upper respiratory tract specimen. Nasopharyngeal specimen is the preferred choice for swab-based SARS-CoV-2 testing. When collection of nasopharyngeal swab is not possible, then the following are acceptable alternatives, and that is oropharyngeal swab, the nasal mid-turbinate swab, and the anterior nase swab. Now, additionally, it's important for patients who develop a productive cough, sputum should be collected and tested for SARS-CoV-2. I think this, Dr. Anil Handu also brought it out pretty well, where sputum is a better sample type if the patient is having a productive cough. The induction of sputum is not recommended because that's going to generate a lot of aerosols. So typically lower respiratory tract specimen and upper respiratory tract specimen. For lower respiratory tract, it could be bronchoalveolar lavage or a tracheal aspirate and a sputum. Now, both of them are typically in symptomatic patients who are probably admitted in the hospital. Upper respiratory tract, nasopharyngeal swab or an oropharyngeal swab. And we should be using only the synthetic fiber swabs with plastic shaft, because calcium alginate swabs or swabs with wooden shafts contain substances that inactivate viruses and inhibit PCR testing. In general, CDC is now recommending collecting only nasopharyngeal swab. If both swabs are used, NP and OP specimens should be combined at collection into a single vial to improve the sensitivity. Now, oropharyngeal swab should be taken from the posterior pharynx, avoiding the tongue. I have seen very often oropharyngeal swabs, the swab itself, it's an effort to reach the posterior pharynx. It generally touches the soft palate or the tongue, and it prevents the right sample being taken. Now, JAMA, Journal of American Medical Association, has taken out a nice frequency chart which indicates the percentage of positivity from specimen types. Of course, BAL is the best at 93%. Sputum is at 72%. Now, the concern with sputum is that it's possible only in symptomatic patients with productive cough. Risk of aerosols when giving the sample, and so we need to ensure safety of people around the person who's giving the sample as well as the healthcare worker. However, often, instead of coughing it out from the deep chest, saliva is submitted, and then that defeats the purpose entirely. But interestingly, you will see that the nasal swab, the nasopharyngeal swab, also is at 63%. So the oropharyngeal swab is at 32%. So you see the nasal swab will detect only 2/3 of the cases, and the oropharyngeal swabs will detect only 1/3 of the cases. So we need to be aware of this while we consider the sample type for COVID-19 testing. So while we are getting into this nasopharyngeal swab testing, we have seen different ways in which a nasopharyngeal swab is being taken. And that is quite a concern, because typically the swab has to go along the floor of the nose or parallel to the palate, and not in any other direction towards the eye or towards the nose bridge. And this is seen better in this cartoon, where the patient's head is inclined to 70 degrees and the swab needs to reach the nasopharynx. It should be in the direction of the external meatus of the ear. And the length of the swab should be such that it almost touches or reaches the outside of the ear. In recent times, there have been paper articles on false negativities in the testing, which is making anti-COVID fight a bigger challenge. And up to 30%, like Dr. Anil Handu mentioned, has been seen in Wuhan. And there are many reasons for this. And I think, in my view, the most important reason is improper collection of sample. Very often we are seeing samples being taken from oropharynx, from asymptomatic people as well who are in the quarantine. It's also about the incubation period of the disease. It's best taken 5 to 7 days after infection, though virus shedding starts from day 2. But it's really difficult to know when a person was infected and how do we identify the 5th day. Transportation of the viral transport medium should be at 2 to 8 degrees for a maximum of 72 hours. If it is going to take longer than 72 hours, it should be at -20. Analytical false negativity due to faulty probes and primers are less likely, but I would put improper collection of sample as the biggest reason. Coming to the testing laboratory, I think Dr. Anil Handu has taken us through very well on various aspects of molecular as well as antigen antibody based analysis, but I've just put up a order from Principal Secretary of Government Health and Family Welfare in Karnataka on RT-PCR as well as rapid antibody based blood tests. Now, from the video conferencing with Dr. Neeraj Agarwal the other day, it was made clear that ICMR does not allow private labs to use serological based methods for COVID-19 disease. So we are not into serological tests as of now. We are only doing RT-PCR. This is a good chart modified from Lippi et al. And it shows how RT-PCR and antibodies play a role in laboratory diagnostics. Now, when you look at the epidemiological surveillance, both RT-PCR as well as the antibodies play a big role, both before and after getting the infection and population-based. But when you look at diagnosis and subsequent monitoring of overt disease, you do not see antibodies playing a role at all. It would be RT-PCR all along. So the reference technique as of now for SARS-CoV-2 is using the real-time reverse transcription polymerase chain reaction. And while it is the gold standard, and Dr. Anil Handu has taken us through all of it, just to reiterate that E gene is the first line screening gene and it's not specific to SARS-CoV-2. However, RDRP, N and OF1AB are additional confirmatory genes that different countries use in different combination. This table gives a summary. China, Germany, Hong Kong, Japan, Thailand, US, and France use different gene targets, and all of them are acceptable by their own governments. Similarly, ICMR has put up its own acceptance, and all of these are definitely acceptable. Of course, the screening gene is the E. If that is negative, the lab is not expected to do anything further. But if E gene is positive, then RDRP, ORF1, AB, and N and or N needs to be tested. Of course, this is giving the same information. There's a very nice article in Clinical Chemistry indicating the molecular diagnosis in an outbreak of pneumonia. And what they did was they took two patients who had ORF1B and N gene in the sample, and they proceeded with diluting the RNA after it has been extracted. When you look at the patient number 1, it has been tested on neat, 10 times dilution, 100 times, 1,000 and 10,000 times. And there's a difference in the way ORF1B and N gene have behaved. You would appreciate that the N gene is detectable even at 100 times dilution, while the ORF1B is negative. It's even more evident in patient 2, where the N gene is positive even at 10,000 times dilution. So they go on to say that the results demonstrated the clinical value of these respiratory samples for molecular detection of 2019 nCoV. In addition, the N gene RT-PCR assay was found to be more sensitive in detecting 2019 nCoV RNA in the studied clinical samples. It is possible that these clinical samples might contain infected cells expressing subgenomic mRNA, resulting in more N gene copies in the sample. So that's the reason why N is more sensitive. Now, once a patient is COVID-19 positive and he's admitted, either symptomatic, asymptomatic, he's admitted to the hospital and he starts becoming symptomatic or worsening, there are a set of laboratory investigation that would definitely help. And CBC has been very elegantly described by both Dr. Sukesh sir and Dr. Anil Handu. But there are other tests in chemistry, including the albumin, lactate dehydrogenase, alanine aminotransferase, aspartate aminotransferase, bilirubin, creatinine, cardiac trope I. HS trope I is a marker that is being used to monitor COVID-19 patients. D-dimer, prothrombin, procalcitonin, C-reactive protein, ferritin, and IL-6. IL-6 has been discussed, of course, but it's also an indicator for the cytokine storm syndrome, which is being seen in very severe cases of COVID-19 disease. And just showing you a screen, meaning images of our lab. This is the area where we receive samples. The sample receiving area has a place where the accessioning is verified. The samples are then taken into the sample extraction, where we have a biosafety cabinet and a extraction automation. That's a biosafety cabinet class 2A, and another one which is a backup in an adjacent room. This is the reagent preparation room, which has a laminar flow, a -20 and a 2 to 8 degrees, and a PCR cabinet for mixing, adding the template, and a pass box where the extracted RNA is transferred. And finally, the amplification room where the cyclers are present. This is basically antibody test, and I think Dr. Anil Handu has mentioned this. I'm not going to go into the details. Coming to the safety issues, I think it's very important while we are in the lab that we ensure complete protection to our healthcare workers, particularly those working in the molecular lab. They are exposed to the samples that come into the lab as well as the RNA. So it's important that they are in PPE along with N95 mask. Now, CDC has come up with an acceptable alternative to PPE, which is a face mask. Of course, it should not be the face mask alone. It should be along with other gowns, goggles, and the shoe cover. For the general population, papers are carrying such news items. You can't step out without mask in the city. And these masks, while people try to wear N95 masks, it is to be discouraged because N95 masks should be preserved or conserved for the purpose of healthcare workers. And a simple homemade cloth-based mask can be used by the general population. This is a nice table which recommends the use of PPE based on various scenarios for medical field staff. And they have listed it on the risk level. So if we are entering an isolation ward or an ICU where COVID-19 patients are being treated, I think surgical mask, glove, shoe cover, goggles, hazmat suit, and N95 are all necessary. And so is it necessary for labs testing COVID-19 sample. However, labs that do not test COVID-19 samples, what the recommendation is, it's surgical mask and gloves. And this is necessary for all departments that are handling samples, which we believe is not COVID-19, but like Dr. Anil Handu mentioned, every sample needs to be considered positive and handled appropriately. So we don't need to have a full body suit to handle a CBC sample. However, a proper maintenance of hand hygiene, glove, and mask is sufficient. The hand hygiene, why, how, and when is very well illustrated by WHO. And the important thing is hand hygiene is therefore the most important measure to avoid the transmission of harmful germs and prevent healthcare associated infections. So it's very important that we comply with hand hygiene while we are in our healthcare settings. It's also, they have put up a pyramid which shows where sterile gloves are indicated, where examination gloves are indicated, and where gloves are not indicated. Incidentally, when you look at where gloves are not indicated, where direct patient care, taking blood pressure, temperature and pulse, performing subcutaneous and intramuscular injections are all apparently not indicated. The CDC also has provided a preparation of viral transport medium SOP, which is very interesting because when large numbers of swabs start coming in, it's important that we try to conserve the resource and start preparing these medium ourselves. There's also a nice website where NEJM Knowledge and AACC Learning Lab have provided tutorials where one could take for about 10 to 15 minutes, and you would get a certificate of completion on the topic of coronavirus disease 2019. So essentially, we need to practice abundant caution. We have to ensure social distancing within our own labs. All departments need to be isolated within their own areas. Earlier, while biochemistry department staff would come to hematology would go to molecular, there would be a lot of cross-departmental discussions, meetings. I think all that has stopped in our lab. Canteen has been closed, except that the food is prepared and food is handed only to one person from each department who then distributes it to all the other staff. Hand hygiene is extremely important. Soap and water, frequently hand sanitizer with 70% IPA should be made available in abundance. Mask, particularly N95 for specific departments within the lab like molecular, microbiology, where body fluids are handled. Surgical mask in the absence of N95, very important at the minimum. Cloth mask is not recommended for healthcare workers in these departments. However, front office staff and other staff can wear cloth mask provided they are maintained well and disinfected on a regular basis. Temperature monitoring of all who enter the building is being practiced, and we need to ensure this so that we at least identify patients who need to be attended to. Now, as we go along in this, we will come across our own staff becoming symptomatic. It's very important to identify them. So we have regular checkups for our staff who go to our physician, Dr. Ajit, and then get themselves examined on a regular basis. we identify the person who needs to be triaged, test them for internal purpose, isolate them, monitor and treat if at all. So to summarize, lab has a significant role to play in COVID-19 pandemic. Safety of healthcare worker is paramount. Fever clinic will triage cases to enable selection of case for testing. Sample collection in asymptomatic and symptomatic cases is very important. How we approach this, particularly nasopharyngeal swab. Testing strategy and protocols need to be understood for better reporting. Lab needs to be updated on constantly evolving strategies for selection of cases, sample collection, and testing protocol. Thank you very much.
Thank you, Dr. Sujay, for a step-by-step explanation of the entire protocol. And I request all the three speakers to unmute their mic and also, if possible, the video. We do have certain questions for all of you. So Dr. Sujay, there's one question that how long is the patient infective and up to which phase?
Oh, that's an interesting question. I think that it becomes evident with Dr. Anil Handu's graph, where he shows how the virus actually progresses, increases in shedding and subsides. I think anywhere from 2 days after infection to, I think, about 21 days is when the virus can be recovered from the nasopharyngeal swab. But the best time to actually do a throat swab is anywhere after the 4th day, right up to the 14th day.
Okay. So there is a question from Dr. Sushrut for Dr. Sujay Prasad. What sample has better chance of picking up the virus, the nasopharyngeal or BAL?
The BAL is evidently the most recommended specimen because that's where I think the virus is causing the damage. And it picks up 93% of cases, whereas nasopharyngeal swab picks up only about 63% of cases. The importance of nasopharyngeal swab comes in asymptomatic and mild symptomatic cases because in such cases, you cannot do a bronchoalveolar lavage. It's an invasive procedure and best avoided.
There's a question from Dr. Amrita for Dr. Sukesh sir. Just wondering if any Indian study so far has covered enough patients to reach to a conclusion in terms of difference in disease pattern in India.
So, yeah, I think ICMR is inviting a lot of proposals for studies. Yes, I have also been roped in through our infectious disease department because I will be doing the cell population data part, but nothing worth publishing at this stage.
Sir, there's one more question for you. This is from a clinician, Dr. Kishore Kumar. Convalescent plasma therapy, as we are talking about the plasma therapy, are tests to quantify titer of antibodies in plasma available. I am a clinician interested in starting a CP therapy once ICMR gives nod. Please share your input on this.
Yeah, so the convalescent plasma therapy is a proposal. I think Trivandrum Srichitra Tirunal has initiated it. For example, we had 2 patients, one is recovered, but unfortunately he's still positive by the molecular method, the RNA method. To be so obviously he still will not be qualifying to donate convalescent plasma. Only if he's negative for the virus will he be, and of course the antibody kits are coming up, and there should be possible to measure the titers in the convalescent plasma, but provided the patient is negative for the virus. The plasma, the article that we published along with Dr. Eban, the gastro department, the hepatology department, was plasma exchange, low volume plasma exchange. But that's mostly focusing on severe illness, which goes into the macrophage activating syndrome.
Okay. Sir, there's a question from Dr. Handu. Will flow cytometry help in early diagnosis and monitoring?
So yes, so if you look at it from that standpoint, I had shown some papers already in which I had very clearly shown that there is a significant population of these cells which are nothing but macrophages taken up on the flow cytometry, having a very distinct forward scatter. If we are going to follow those studies, it's very obvious that whenever you are able to figure that population out, and if they are also showing concomitant activity markers, you will be able to look at the patient with suspicion of possibly a COVID. Eventually, when you follow these patients up, the number of these cells go down significantly. And also at the same time, you are able to see the activation markers also going down significantly. So that eventually gives you a possibility of following them up and also getting an idea of how to go about, in some of these cases, go ahead and do the testing for COVID, especially in the time when you're trying to ration your tests. Having said all this, it is not a diagnostic test per se, number one, and it has only a role to play in a follow-up of the patients. At least that is how it is currently. There is also a lot of work going on parallelly between people where they are trying to see whether all these tests together can develop some kind of a score or algorithm which can predict the possibility of finding out patients who are suspected in upper respiratory tract illnesses that they might actually be COVID. But it's still not come to that extent that people can just depend on it reliably. So as of now, RT-PCR is the gold standard. We all need to accept that. Number one, antibody testing together with RT-PCR is a better modality. Number two, and obviously, if we are able to get these ancillary techniques into the picture as well, who knows? Maybe we'll be able to get better information.
Okay. Dr. Sujay, there's a question from Dr. Jayesh Trivedi. He's asking if anyone knows the IgG titer ELISA or CLIA kits approved by ICMR for passive immunization.
I think there has been a blanket statement by Dr. Neeraj Agarwal about serological methods by private labs. And I think it was made amply clear that private labs will not test serological methods as of now. That may change as we go along, but at this point in time, this is the information I have. But obviously, for the understanding of vaccination status as well as past infection, the role of IgG and IgM, both for epidemiological purpose and herd immunity, will take importance.
Okay, so there is a question again. This is a question from Dr. Surgeon to Dr. Sujay Prasad. He's asking if a laboratory person comes in contact with a positive case, are there any criteria of quarantine for other laboratory staff members and any experience with my lab kit?
Okay, I think there are two questions here. The second question is my lab kit?
Yes, sir.
Or is okay.
Yes, sir.
The first question is a good one because we went through this process of trying to understand. We have a 60,000 square feet facility where 200 people work. So the concern was, even if one person falls sick, do we shut down the entire building? So that's where we started looking at models from Singapore and other countries in Asia, where information came that within the building, people are advised and recommended to stay within their departments without moving between departments. So even if one person falls sick in a particular department, only that department shuts down and not the entire building. So we immediately put a policy and we put across a statement to all our staff who are in the building to maintain social distancing, isolate themselves into specific departments without interdepartmental meetings. If at all there is, it should be on video, and avoid reaching the canteen. Now, canteen is open only for preparation of food, and food is transported to the departments. Each of the department, though NABL does not recommend food being eaten in the department, I think these are unprecedented times, and we have made designated areas within the department where food is being taken and had. In addition, what we have done is, because the workload has come down to 20% of what we had, we have scaled down our working force to ensure that there are backup teams at home. The teams at home are told very clearly it's not holiday. It's a backup team that they have to prepare in the event, even in the eventuality where the current staff falls sick. So I think that is very important for us to follow. Otherwise, it's going to be extremely difficult to shut down. What happened in one of the hospitals in Bombay is testimony to that. Now, coming to the MyLab kit, in fact, we started with the MyLab kit, and I think it worked well. We had validation, initial validation, followed by some testing, and it worked well. We had no concerns on the MyLab kit.
So there are two questions for Dr. Sukesh. There's one from Dr. Nishit Gupta. So he's asking any role of HFLC parameter in screening while seeing CBC?
At this moment, no. In fact, if you look at most of the, right now, the most parameter which is identified as unique parameter which is identified as monocyte Z, which Dr. Anil had shown it on the flow cytometer. Monocyte Z is actually the forward scattered data on monocytes, which of course is increased in patients. But again, they are increased because there is changes that Dr. Anil reflected, but the increase is mostly towards getting worsening scenarios rather than a diagnostic. So it's mostly a prognostic tool. The HFLC, of course, is definitely not the other way as you can use in viral infections like dengue. So we'll have to see, because the number of cases have to be seen, especially in centers which use hemocytomorphometry, which I think are plenty in India compared to other countries. So maybe something will be identified over a period of time. It has to be either centers in Delhi, Bangalore, where there are more patients. In Vellore, there are hardly any patients. And you must realize that most of the cell counter data should be obtained on samples which should be processed within 4 hours of sample collection.
So there's a question from Dr. Reshma Nambia. She's asking, effectively, how many samples should be negative to clear a suspect case of COVID-19 as a negative? So how many samples need to be...
This is a question for...
so you can answer, or maybe Dr. Handu can answer.
I think Anil can answer.
Yeah.
So the question is, if I'm suspecting, first of all, if you're dealing with somebody who's asymptomatic, at least at this point of time, I think we should just leave him alone. However, if you're feeling that there is some kind of a possibility that the person might have developed an infection, so in such a circumstance, as per the ICMR guidelines, the current status is pretty clear. We need to take a sample of RT-PCR and we need to go ahead for testing. The important point with Dr. Sujay also very clearly mentioned in his presentation was appropriate sampling. So as long as we are making sure that the sampling has been done correctly and has been taken appropriately from the nasopharynx and that particular test is negative, the patient is considered for all practical purposes negative for the COVID virus. However, for their own safety, it is preferable such people should be quarantined for 14 days within their own confines in their own homes. And post that 14 days, if he still wants to figure out and he's not symptomatic at all, we will, for all practical purposes, consider this person as not having the infection. However, if a patient has had a test which was negative and eventually the patient started developing symptoms, I would surely want to repeat this patient's test on day 5 and then be on day 5 and see whether we are able to get this possibility or not. The bottom line still lies in one fact: we have to take the sample appropriately. If we are not taking sample appropriately, the possibility of false negativity is very, very, very high, and that's almost about 33% in one of the studies which has come about. So not a clear answer to this, but as I had mentioned in my presentation, if it was given to me, I would prefer to do the RT-PCR with the antibody testing, and I would prefer to do it 3 times, one on day 0, one on day 7, and one on day 14. And then interpret the test the way I have mentioned in one of the interpretation slides which I had mentioned there. Having said that, this is not the one which is approved by government. So please follow the ICMR guidelines. Don't take my word for it. I'm nobody in this whole scenario at this point of time.
There's a question for Dr. Sujay Prasad. Should we transport COVID suspected sample through pneumatic chute system?
I think it is very clear that COVID-19 samples need to be handled discreetly. There is no, I don't know whether there have been studies on whether it can be transported through the pneumatic tube, but I personally recommend not to transport it through pneumatic tube, because it is possible that the tube can open up and there is an aerosol or a contamination of the tube. So please avoid transporting COVID-19 VTMs through the pneumatic tube. Please hand carry it either in the lift or through the stairs.
So there's one more question for you, Dr. Sujay, from Dr. Tushar Toprani. So he's asking your view on self-collection of swab during mass surveillance.
Incidentally, this is a good question. So I was trying to understand how the patient experiences a nasal swab. So what I did was I went ahead and did the self swab for myself. And it was interesting to see the experience, because first and foremost, I had to select the right swab. And the swabs that were in front of me were cotton swabs. There were Dacron mesh swabs, which was thick, and there were Dacron mesh swab, which was thin. Now, there's no way a thick Dacron mesh swab is used for nasopharyngeal swabbing. It is the thin, flexible Dacron mesh swab that is used for nasopharyngeal swabbing. And though I was able to do it with less discomfort, my colleagues have been telling me that it's not appropriate that we tell our patients to do the self-swabbing, because the swab has to go deep into the nasal cavity, straight towards the throat. And for me, the experience was initially, it was a bit ticklish, but as I went deeper and I hit the nasopharynx, I could hear in my ears a rub. So it was a peculiar experience, because that's when the Dacron mesh actually bent and started going parallel to the nasopharynx, and I had to twist it to collect the sample. So with all of these, I don't think it's appropriate that we recommend self-swabbing by the patients. It may not be appropriate.
So we do have few more questions. So if you're okay, shall I continue asking?
I'm okay.
There's one question that was asked in the beginning. It's about a lot of issue about hemoglobin, because they have been mentioning about the virus dislodging the, playing around with the heme, and that could be the cause for the effect of the lot of respiratory issues. So thing is, yes, if you look at it, we don't have to look at the virus pathogenesis, or we can actually look at the fact that, okay, if there is going to be such an issue, there will be intense hypoxia. And obviously, the hypoxia can result in increase in erythropoietin. So far, there is no publication which talks about erythropoietin levels in patients with COVID. Probably that's something that may be coming up. So if the erythropoietin levels are higher, that could indicate that the proposed pathogenesis is actually true. The other thing could reflect in the form of increased hemoglobin. But the problem is we also see increased hemoglobin in dengue because of not related to any erythropoietin or erythropoiesis issue, but because of less water content. So that the level of hemoglobin may not be useful. Maybe the RDW could indirectly reflect this particular issue that we're talking about, but I think erythropoietin levels can be looked at.
So there's one more question for you from Dr. Chandana, Dr. Sukeshwar. What surrogate markers you would recommend, hematology or biochemistry, at onset when PCR negative individuals still it can be a false negative?
Obviously, when we showed some parameters, these are parameters which are prognostic parameters, both in chemistry as well as hematology. I think if you're going to monitor some of those parameters, maybe you have to look at the cost factor. And I think I would generally look at cell counter data because that would look at even recovery also as compared to biochemistry. But I'm a hematologist, so I may be biased.
May I?
Yes, sir.
So what has happened is false negatives with a clinical suspicion. People have looked at CT scan and proceeded based on CT scan findings. I have not come across laboratory findings being used as individual parameters or as combined multi-parametric approach to look at negative RT-PCR clinically suspected cases. They seem to be going the radiology way rather than the lab for such cases.
Dr. Handu, there's a question for you from Dr. Nilkan Poddar. He's asking any strategy of hydroxychloroquine to lab staff.
Yeah, I can only tell you the strategy which has been given across by the ICMR, and the same stands adopted in our hospital as well. Incidentally, I have also taken hydroxychloroquine. What we need to keep in mind is that for all the healthcare workers, what is expected is that you would have gotten your baseline electrocardiogram done. This is the practice which is being followed in our hospital. And post that, you need to get physically examined by a physician in our system. Once he has approved the fact that your baseline cardiac issues are not there, they then give you the medicine is given by the hospital to us. And in fact, I have also received the entire course for myself. We had to take a loading dose of 400 milligrams twice a day for the first time, and then eventually every week 400 milligrams, which I'm supposed to continue for 7 weeks. We have also been given an advisory to go ahead and even give our contacts, which are at home, my family, except the children who are less than 15 years of age, in whom again they're expected to give similar kind of a dosage. However, the duration is going to be only 3 weeks. So I have not followed that part of it in my family though. As far as I'm concerned, I have taken already the hydroxychloroquine. I don't know whether I'm immune, not immune, whether it helps me or not helps me, but with whatever literature is available, it seems to be doing a little bit. So, so far it's not going to trouble you. I think it's an okay thing to do.
So there's a last question now for Dr. Sujay. What precautions should we take in case we have to centrifuge a COVID patient's sample, say for PT or APTT test? Centrifugation.
Interesting question. So I think it's only because now COVID has exposed itself that these questions will start coming up. There is no doubt in my mind that at this point in time, there's no point segregating COVID only samples and using a separate centrifuge for it. What is important is that to maintain the centrifuge adequately, it has to have its preventive maintenance. The balance is very important. When we put in the tubes into the centrifuge, maintaining a good balance of the centrifuge will minimize the risk of possible damage to the centrifuge and thereby damage to the tube that is in the centrifuge and contaminating the centrifuge. From the tube itself, per se, I don't see any need to handle it any differently from other PT or PTT samples. Dr. Sukesh, what is your take on this?
I didn't listen to you, Dr. Sujay. Can you repeat that?
Yeah, this is basically PTT samples taken from COVID positive cases. What precautions should we take while handling them in the lab?
So, in our lab, we just treat it as a routine sample with the same precautions that we give for all samples as a potentially infective sample. We do allow pneumatic transportation. That's because the fear of sample leakage does exist, but we have made sure that because we get samples only from our staff which collect, so we have been repeatedly telling them to use the pneumatic, the evacuator tube systems, needle and needle holder. So the fear of, and thing is, there's one more secret that we have, that is we, during the COVID season, we decided that we will only distribute grainer tubes instead of BD tubes, because grainer tubes, when you open it and add sample and recap it, you can't just recap it, you have to screw it in. So that prevents sample leakage in pneumatic system. So that's one way, because pneumatic system, because we are working at less than 25% of our staff now, It's a manual transportation of samples manually is not going to be easy. We are using pneumatic system, but of course, we are treating PT and APDT samples the routine way, but with a lot of PP precautions.
Thank you. I think that I need to clarify there. The question earlier asked about VTM to be transported on the pneumatic tube. I agree with you that coagulation tubes can be sent on the pneumatic tube, but the VTM
but
should be handled.
When you were answering that question, your point on sample leakage in the that hit me really well, because I know that that's a possibility, and that can cause a lot of aerosols. Yeah.
Yes.
So with this, I thank all of you for such an interesting and very informative session on COVID-19, and also most of them have cleared many of their doubts. Also, there are still many more questions keep coming. So in case we get more questions, we'll connect with you again and we'll share with you the questions and you can answer it separately.